So I think to sort of attack, this is kind of almost a philosophical question about the number of drugs you need for effective combination therapy, and it's, I guess, become of greater interest over the last few years as a number of groups and people have looked at two-drug therapy, which when we proposed, actually at the Kirby, when I went back there in 2007, we proposed a two-drug switch study, and we were really considered, I think, pretty, I don't know, what's the word, David? It was, we were considered cowboys, I guess, and really doing something that was against, the strict rule that you need 3 drugs in order to control retroviral replication. So, in order to give a little bit of context, I think it's worth thinking about the history in the way in which our understanding of antiretroviral therapy evolved. And, if many of you, some of you will remember all the way back to the 80s when AZT finally became available. And you'll remember that we made an error in retrospect of we only had AZT and we gave AZT to people. And what you generally saw, as you can see in this slide, is that you got a sort of modest decline in viral replication, around a 0.05 to 1 log drop. And you got a slight CD4 count rise, which was the aim of the game in those days. It was about improving CD4 as a marker of immunodeficiency. And then what we generally saw, in fact what we saw with everybody really, with single NRTI therapy, is that eventually, ignore the x-axis, eventually the activity in terms of both antiretroviral replication, antiretroviral suppression waned, and of course as that waned, usually with something of a lag, the CD4 count dropped. And so after a while we realised that AZT monotherapy just wasn't enough to really give people the kind of antiretroviral suppression and immune boost that was required. And then we got to dual therapy. So in the early 90s, probably when I started actually became a doctor in sort of 93, I remember giving people AZT and DDI. And what you saw with that was a slightly improved antiviral response, so around a 1.5 log drop, AZT DDI. Some people remember AZT DDC as well. But once again, that effect waned. And the CD4 count rise was slightly improved, but once again, as antiretroviral suppression waned and resistance developed, the CD4 count eventually dropped. So again, we were stuck with 2 drugs not really being enough. And then as mentioned by Chris Bayer today, in 1996, the famous Vancouver conference occurred, and at that stage, instead of there were a number of experiments, and they're very interesting to look back at, but basically if you gave a protease inhibitor or a non-nucleoside reverse transcriptase inhibitor, and efavirenz and nevirapine were both around in the early 90s, mid-90s I should say, and gave that to naive patients in combination with 2 nucleoside drugs, you got a terrific response. You got a much more powerful, see here, suppression in viral replication, and you saw a really marked improvement in CD4 count. And we know, of course, everyone remembers that since then we've understood that 3 drugs, combination drugs, are important to get not only suppression of HIV replication, but maintenance, as long as people can take the drugs, right? Which is, again, something we had to learn shortly after the 1996 conference. So what are the possible lessons from that early experience? And I think the lesson that was really promulgated, and it was a reasonable conclusion, is that you need 3 drugs. 3 drugs work better than 2 drugs, and they work better than 1 drug. And 3 drugs is, and I remember being taught in, I guess, 1996, when I was about to do my exam for the physicians program. I remember Andrew Carr taking a group and saying, writing on the board, dual therapy is dead. Triple therapy is the answer. And that was kind of the mantra. That's what we've all understood, and I think a lot of people would say that's still what they understand as being the best option for people. Incas is an interesting study, and it's interesting for a number of reasons. It was actually presented at that Vancouver conference, but perhaps didn't make the same splash as the protease inhibitor studies did, because this was actually a study that looked at different combinations of either dual therapy with either 2 nukes, a nuke and a non-nuke, or triple therapy with 2 nukes and nevirapine. And it's called Incas because this was a study that included Italy, the Netherlands, Canada and Australia. And David Cooper was one of the PIs, as was Joep Lange and Mark Weinberg, both of whom, pause to say, are no longer with us, sadly. Joep, as you know, died a couple of years ago, and Mark, unfortunately, tragically died this year. and they were both involved in this study. And it really tells us a lot about what we understand about triple therapy. So what's interesting is if you look at the red line down here, this is antiretroviral naive patients who were receiving, in the red line, AZT and nevirapine. So a dual target, if you like, therapy, both on reverse transcriptase, but one acting as analogues and the other one acting to change the catalytic site of the enzyme. And what you can see there, and it's very instructive, is they got a very tiny improvement in virological suppression, and they completely failed. All of them had viremia at 8 weeks. When you think back on it, AZT in this study was given as 200 milligrams 3 times a day. We know it was pretty intolerable. And nevirapine was given, as you recall with nevirapine, we have to give a 2-week induction with 1 tablet per day, and then you go to 2 tablets, which was, in those days, 1 tablet twice a day. So in terms of adherence, it was a bit difficult, a bit complicated. The second study looks at AZT-DDI, and what you find is that even though it's not a terrific response, about 15% of patients after a year are still suppressed. And they're probably people with fairly low baseline viral loads, right? There are still experiments showing that if you start with a viral load less than 50,000, in a majority of patients, people will get away with dual therapy. And this, of course, is the triple arm. This was AZT, DDI, and nevirapine, and about 60% of patients were suppressed after 52 weeks. And while that was not great by today's standards, in those days that was a really great result. 60% of patients undetectable at a level, mind you, of 20 copies per mil, so pretty stringent, or undetectable. So once again, this sort of got translated as you need 3 drugs in order to achieve and maintain virological suppression. The other studies that are interesting in terms of triple therapy, so some of you will remember trizavir. So trizavir, because it was 3 drugs, was marketed as being, HART, or highly active antiretroviral therapy. And I recall the studies that were developed, I think by Glaxo at the time, that were smallish, but they suggested that triple therapy with 3 nukes was fine. It was only in the patients who had over 100,000 copies per mil where it was thought you couldn't really use it. It wasn't as potent as triple therapy with another class of drug. Until this study was done. This was ACTG 5095. And what you can see here is that it was a little bit complicated in that you had a third arm where they had 4 drugs, but ignore that for the moment because actually this study was stopped by the DSMB only about 9 months into the study because it was very clear, even at that stage, that the rates of virological failure in people getting trizavir or the triple nuke arm were much higher than they were if you were getting efavirenz. So if you're getting efavirenz with the 2 or 3 nukes, you did much better. And that kind of was the end of the notion that triple nukes was equal as 2 different antiretroviral classes in a 3-drug combination. And you can see here quite convincingly that in the pooled efavirenz arm, 74% were less than 50, whereas only 60% with trizavir. The time to virological failure was shorter with triple nukes, and even if you suppressed in a post hoc analysis, the chances of rebounding to levels of 50 or 200 were higher. And that was kind of the end of trizavir as equivalent as other combinations with powerful suppression and maintenance. Another study where 2 drugs has been studied against 3 drugs is ACTG 5142. This was published about 8 years ago by Sharon Ridler in New England Journal. And what this showed was, and I'm only picking out the people with the high viral loads now, so these are meant to be the patients who are most difficult to suppress. And we know in general, patients nearly in all studies who have high viral loads have much poorer levels of suppression than patients with lower viral loads, right? It's really been found as an important variable in all studies. And what you see here is that the important thing about ACTG 5142 is a lot of people thought protease inhibitors were naturally a more powerful agent and they should do better than efavirenz with 2 nukes. And this study was very convincingly showed us that that was mistaken. In fact, the efavirenz and 2 nuke arm, which you see here in the blue line, yep, there we go, was actually more successful at suppressing patients and maintaining that suppression. But if you look at the PI, which was lopinavir and 2 nukes, versus lopinavir and efavirenz, so only 2 drugs, in fact, the outcome was about the same. There was no difference separating those 2. And this was really the study that, from then on, A-tripler became really the treatment of choice and, lasted a long time until the era of integrases, of course, which we're in now. So, can you advance it forward. It doesn't seem to want to go for me. Here we go. So we had an opportunity when I was at HIVNAT. I worked in Thailand for a while until about 2004. We had an opportunity to actually look at viral decay dynamics, because the question was, well, if you block 3 targets, or if you block 2 targets, if you block 3 targets, do you get a better response? And perhaps you can measure that in terms of the degree of the rapidity or the acceleration of viral decay. This was a smallish study, but we were quite well powered actually to show a difference. We had 22 patients. And the patients in the 2-target arm were getting reverse transcriptase, and that was a non-nucleoside, it was efavirenz, and they were getting boosted sacubitril. Okay. In the 3-target arm, they were getting reverse transcriptase, and they were getting protease, and they were getting T20 or infuvitide. Okay, so it's blocking 3 targets versus 2, and you might think, as a common sense thing, well, the people who are blocking 3 targets may well do better. But as it turned out, that really wasn't the case. This is actually the 2-target arm. Here's the 3-target arm. We had about 11 patients in each, and what you're seeing there is all of their graphs and the median drop here in the log. And you can see that, in fact, if anything, to be honest, there's if you look at the numbers, it's slightly improved in 2-target versus 3-target, but statistically completely not different and probably just a chance finding. And we saw no difference in either first phase, second phase, or overall viral elimination constants. So again, suggesting that maybe having more drugs, 2 drugs is enough, and maybe 3 drugs is adequate. So what are the possible lessons from all that? And I think they are that 3 drugs from the same class are not necessarily better than 3 drugs selected from 2 classes. I think we've shown that with, particularly 5095 with trizavir. The other possibility is that 2 drugs from independent classes can be as effective as 3 drugs from independent classes. And I think what's important, probably, particularly when you think about Incas with 3 times a day AZT and different dosing of nevirapine in the first 2 weeks because of its induction, that convenience, tolerability, toxicity, and the fragility of the drugs you're using are key to which particular combinations work. Okay, and I think that already comes down to adherence. I think again and again and again we've been fooled that really. It's like Koopman said from the FDA, if you want the drug to work, patients need to take it. We've learnt the hard way over the last 30 years that that's absolutely critical. We had an opportunity to actually do a systematic review and meta-analysis of the use of 2 drugs versus 3. I'm not expecting you to be able to read this, but I just want you to concentrate on this Christmas tree plot. These studies here are all first-line trials with viremia, and this bunch here are switch trials where patients have been taken with already successful viral suppression and they've been switched. Okay, and what you can see is that essentially, whether you're in a first-line trial or whether you're in a switch study, and you can see the size of this plot is obviously bigger because there are smaller numbers of patients, and the overall, there's a suggestion that maybe it slightly favours triple therapy overall, but it's not significant, the difference. There is suggestion here that basically 2 drug therapies are as good as 3. But the important thing, by the way, is that we excluded maraviroc-containing trials here as an a priori part of our statistical analysis plan, because it was very clear, I think, to everybody that maraviroc just didn't perform as well at that stage. And so, if you exclude maraviroc from any of the switch drugs or the dual therapy drugs, essentially it's very close to being the same as triple therapy. SWORD you're going to hear about from a minute from CC Hung, so I won't go into any great detail. In fact, I won't at all, just to say that it worked, all right? CC will spend 15 minutes drilling down on the details of that study, so I'm not going to steal his thunder. You would have heard of PADDLE. So PADDLE is been done by Pedro Khan in Argentina. Pedro was meant to actually give this talk today, but unfortunately he wasn't able to make it. And this is just a cohort study looking at patients who were viremic, but without a viral load greater than 100,000 at the screening, and giving them just dolutegravir and 3-TC. So two classes, nucleoside, and integrase inhibitor. And it's not randomised. This was just a proof of concept. And what's interesting, actually, despite screening all being under 100,000, some of these patients did have quite high viral loads, well over 100,000. And what you see is that by week 8, all those patients were suppressed. This one was stopped because of a serious adverse event, and this one actually had protocol divine failure. All right, but an interesting concept. Very simple treatment, 2 pills, which would be easily made into one single pill if it worked. So this could be another single tablet regimen. And this now is in much larger studies done as phase 3, which should be reported quite soon. So which dual combinations clearly didn't work? And I think we can say that 2 drugs from a single class doesn't work. It may work for some very specific patients, but in general, it's not something that I think that should be researched further. I think Maraviroc in any 2 drug combination is really not, there's no reason to continue to examine it. It simply hasn't worked. And a non-nuke and 1 nuke, as evidenced by Incas and also studies like Cool, and these are all reviewed in the systematic review that we published last year, don't cut it. But which dual combinations actually warrant further study? And I think the agents that have shown promise are a boosted PI and a single nuke, a boosted PI and an integrase. And I think if any of you were here this morning, you would have heard a bit about studies looking at that combination, which a lot of people are interested in. Boosted PI and a non-nuke, an integrase and a non-nuke, and possibly an integrase and a nuke, like paddle, for instance. So I think they're the ones that have promise. This is almost a bit the wrong way around, but I mean, why should we study these? It's often said, well, we've got triple therapy, we're all very happy with it, dual may not quite cut it, why are we studying this? Well, I think there are a number of reasons. First principles, first do no harm, and the more drugs you give, the more likely you are to cause someone harm. It seems to me to make sense that we use 2. If you think of all the other areas of medicine in which we work, we generally try and limit the amount of drugs we give to people. We don't treat hypertension with 3 drugs if we can get away with 1, right? So I think that I understand that diseases are different, but I think we need to think about first principles. Only use as much drug as you need to control the disease that you're treating. I think we need to maximise tolerability, minimise toxicity, reduce pill burden, which optimises adherence. And that's all really the way in which I think antiretroviral development has gone in the last few years. We're all moving towards single tablet regimens, if at all possible. And of course, injectables are coming, they're only a year or 2 away, possibly from the clinic. I think we need to maximise quality of life, and some of you would have seen debates about whether we should have 90, 90, 90 and 90, so 90% of people having an optimised quality of life, whether we should have some variable in that actually talks about people's quality of life rather than just them being suppressed. And that's a debate I'm sure that will develop and continue as time goes on. And of course the other thing is that we do have to treat people, if you're treating a 20-year-old and you're expecting to get to 80, that's 60 years of antiretroviral therapy. And of course we've only been telling the story of HIV for the last 30 years, and the last 20 odd years really in terms of treatment. So even though I think we think, well, patients may only need 1 regimen, we've only really been documenting this for 20 to 30 years, and we're looking at 60 years of treatment in some cases. So I think we have to be a little bit conservative about how we expose people to drugs. The other thing, of course, is reduced costs, and that's not just an issue for middle and low income countries, it's also a question for rich countries where we're struggling with a really, really difficult and ever-increasing health budget and ageing populations. So cost is important everywhere. So what are the conclusions? Is it perhaps time to change the way we talk about antiretrovirals? Should we be talking about optimised therapy rather than triple therapy? Or just talk about combination therapy, which is, I think, what a lot of us have been doing in the last few years. I think the optimal regimens will result from dual-class drug combinations that are potent, tolerable, non-toxic and convenient. But I don't think there's any doubt, and I'm certainly not advocating that we should all switch to dual regimens. I think we need more research. We need to make sure that these dual regimens, if they are good over 1 year, that they're also good over 5 to 10 years. So we need to look at longer than 48 to 96 weeks. And we need to obviously monitor for long-term safety. And with that, I will conclude. I'd like to thank David Cooper, who's been my mentor and terrific colleague for over 20 years now. Cal Cohen, some of whose slides I borrowed for this presentation. Pedro Khan, Jean-Michel Molina, and Trip Gulick. Thank you.